Welcome to our Wednesday coffee chat with elder care attorney Robert Slutsky. And we have our special guest speaker on here today, Dr. Rob Pearlstein from Suburban Geriatrics. And together we are going to have them offer you a webinar on cognitive impairment, medical diagnosis, and they're going to offer some tips for you and some information about how to identify when somebody is experiencing cognitive impairment. So thanks so much for joining us today. And Rob Slutsky, if you'd like to share a little bit about yourself, and then we'll have Dr. Pearlstein share a little bit about himself as well.
Okay, well, I am an elder law attorney. I've been practicing for 28 years. I have a private elder law practice where I often seek out kindness and assistance by Rob Pearlstein for help in assessing my clients or people who may need help. I have a private practice which is based in Plymouth Meeting, about a half a mile from Rob's office in Plymouth Meeting. But I also have an office in Malvern and in Radnor. So while I am a private practice attorney, I am counsel for the Montgomery County Office of Senior Services. I've been doing that work for more than 21 years at this point. It's been a long-term relationship. That's probably where I met Rob. I don't even remember where I met Rob. It's been that long. It's probably close to 25 years that Rob and I have known each other. And he has been an extraordinary resource for me because oftentimes I need to get a bead on whether someone is capable and safe. And I will tell you that despite having probably the single largest geriatrics practice in the 5-county region, Rob is the most down-to-earth, helpful mensch you'll ever meet. Because he never asks when I call and I say, hey, I need your help. He never asks, well, I don't know if I can make it, or do they have enough money to pay me? He doesn't care. He always just is like, okay, tell me where, tell me when, get me the connection with the family, and I'll go over and see if I can help out and get the person in a safe environment. So, he is a kind guy, but wonderfully, he also has, I believe, 14 physicians working for him, as well as 30 physician extenders or more. So it's a really big network that we can tap into to get help in Montgomery, Chester, Delaware, Lebanon, Reading. I mean, he's pretty much everywhere. I'm not sure he's not been cloned, and this might not be the real guy here, but when you hear, you'll understand as we talk together, because we, again, have been friends for a long time, how knowledgeable and how willing to help Rob is. I'll let him introduce more if he wants to.
I guess it's up to me.
Well, you turned yourself off. You muted yourself.
Sorry about that. So, yes, Rob and I have known each other a lot of years, and I think that I think our friendship actually started because of the of Montgomery County and a lot of the issues that we've had to deal with people in the county that have had issues. And interestingly enough, we work well together because obviously Rob is much better with the estate issues, and I do more with the medical issues, and a lot of it actually merges. And for a lot of people that don't have a lot of family or a lot of help, I think that they actually need a lot of support. And I think that the two of us together have worked with a lot of people. So I really appreciate that. So today, I was asked to discuss a little bit of cognitive impairment. And this is not, I'm doing this more of how to approach someone that is starting to have issues. And I don't really want to dwell on the later effects, the dementia, the problems that happen, post confusion and incapable situation. I really want to talk a little bit about what do we do and how do we do it? And I get phone calls from actually a lot of friends, because now that I'm approaching 60, my friends' parents are all approaching, 80, 85, 90, and the big, I guess the difficult question is when and how. So when do we worry? When do we think that there's an issue? One of the things that I like to say is confusion is not a part of aging. It is not by definition a normal part of aging. It is very common, but is not normal. And with that said, is yes, if you're 95 years old, the chances of being totally cognitively appropriate are very slim, but it's not necessarily normal. So starting in your 50s and 60s and 70s, if there are some cognitive changes, and what does that mean, cognitive changes? We use these big words. It could be memory issues. It could be a little bit of confusion. It could be a little bit of personality changes. It could be really anything that's not the same as it was. And unfortunately, as we age, things change. You know, we all know it. You know, no matter what age we are, we know that we're changing. And one of the common problems that happens as we age is we compensate. And just like with if we have knee pain, we compensate by using the other leg, or we exercise more, or we go to physical therapy. If we have problems with our eating habits, whether it's a lot of reflux, we change the diet that we eat. Well, the same thing happens when we start having memory issues, or we start having problems with maybe doing math. What do? We compensate. And sometimes we compensate by pretending it's not happening. And a lot of times that's one of the problems that we see, is that the person that knows inside that they're having issues push us away and say, no, I'm fine. I know what I'm talking about. And that's a little bit of a problem. So what do? So if one of you recognizes, or someone calls and says, my aunt or my wife is just not the same as she was, you know, whether it's a little bit of memory issues, whether it's a little bit of inappropriate behavior, what do? Well, it's very important to have that analyzed. It should be, we want to quantify when people are getting older. We can't quantify heart disease. We try, but it's hard. We can quantify cognition, because there's a lot of testing we can do, which will give us a number, will give us an about how someone's doing. And the important part of this is the sooner that we address the issue, the sooner we have an idea of what's going on, and then the sooner is treated.
Rob, let's talk about that number. When you talk about that number, are you talking about like a Folstein?
Well, there's multiple mini mental status, there's BIMS, there's Montreal Cognitive, there's a lot of different testing. And honestly, it doesn't really matter which test you use. If you have some issues, you have some issues. So the issues are, each one of the cognitive testing, it kind of specializes in a little bit of different cognition. But when it comes down to it, if your cognition is not all there, you have an issue. Now, what will happen, a lot of these are screening tests. So we screen. And if we see that the screen is abnormal, or the screening test has some issues, then we point to, well, where do we think we need to go from here? And that's why when you go to the drugstore and you get your blood pressure in one of those little machines, doesn't matter who does it or what machine you use. You
Rob,
can't do that with cognition.
You mentioned the screening piece of this, and I'm going with stuff that you've talked to me about in the past, and I think it would be helpful for the audience to understand. So in the past, you've kind of told me these are very rough determining screens, meaning someone who could have a 29 out of 30 on a mini mental may still need help, but it's very clear if someone gets a 10 out of 30 that they absolutely need help. Is that pretty much the way it is with all the tests?
Yes, they're all well, all the screening tests are very similar. Some are a little bit more memory oriented, some are a little bit more calculation. You know, there's different ways let's back up. Does mostly everyone understand or know what a mini mental status is? Everyone? No? Okay, great. So a mini mental status is a screening test that was invented about 50 years ago. And all it is it's 30 questions. And what they did is they divided your brain or your cognition into different stuff, such as memory, such as calculations, such as being able to say a sentence. When you do this test, it gives you a score, and the score is out of 30 points. Now, people say that you can forget, for instance, your address. If you don't remember the zip code, but you remember your address, you get 1 off. So it's a screening test, which doesn't necessarily tell you exactly where you are, but it tells you that there are issues, and it tells you where to point to get more specific about those issues. So screening tests like the mini mental status just are a screen. So it's not, even if you got 5 points off, doesn't mean, oh my gosh, you can't do anything. But it does mean that you do have some issues and you need to look further into it. So for instance, in a practice like mine that sees older folks, we do testing every 6 months. And why do we do it? Because it's a screen. We want to see if someone's changing every 6 months to a year to see if there is a need to find out more what's going on. Now, there are some things like depression. People that are depressed appear to be cognitively impaired, and not necessarily they are, but because of the depression, their thinking is not as sharp as it could be. So that's why it's so important to do screening. And from my end, the screening leads to what's next. If I have a 90-year-old that we do a screen on and they do fairly well and they only miss a couple points, then I'm not real concerned, and I'll re-screen them 6 months later. If I have a 66-year-old that comes into my office that is having issues, or someone feels that they're having issues and we test them and they score a 27, I'm concerned. So what do? Well, we have things that are not screening, that they are more specific. And the big term we use is neuropsych testing, which is a 6-hour test that really picks apart your brain to know exactly what's going on. I don't use this for everybody. But my point is, and the importance here is, when we're getting older, it's important to know how our mind is doing, because the sooner that we get on top of this, the better we can treat it, the better we can address it, the better we can move forward. You know, when Rob and I talk about certain people, if some of their legal issues were taken care of when their cognition was just a little bit off, it would have saved a lot of money from a legal end, because things could have been done, taken care of, and we could have been more on top of what the future will be like. And that's why it's so important. I think that it can't be blown off as she's getting older, she's a little forgetful, that's okay. I think that's the biggest thing here, because if you do that today, what is tomorrow going to be like? Or what is 6 months down the road going to be like? And if we anticipate that a little problem today can be a much bigger problem tomorrow, I think that that's the most important part of why it's important to recognize that if you have some issues, and they can be very, very small, and you can come to me and I can say, you're fine. That's good.
You know, you just made me think about something which I think is really relevant to this part of the conversation. You know, when you diagnose someone with dementia, or when I see coming off a report from you guys or a neuropsychologist or somebody, and they say undiagnosed, or they can't assign which type of dementia is, they'll say likely Alzheimer's, or they'll say likely Lewy body, or they'll say likely, you know, whatever. And my experience is that some of these dementias are more harder to manage. than others. In other words, the behavioral problems with some of them are worse than others. Some people become more benign and, you know, they're more disoriented, but they're not aggressive, they're not nasty, they're not physical. First, could you briefly just pick a couple of the big ones and kind of go over the characteristics of those dementias? And then, if you could, on the ones that you can, could you explain how you make that diagnosis? In other words, how do you say, is it Alzheimer's or is it Lewy body? Is that something you can test medically? Is it an MRI? Or is it mostly about categorizing symptoms and saying this person has these symptoms and therefore we're going to put them in this category?
Okay, so you asked a whole lot of questions in there. So so when someone comes to me initially, and I mean initially, when they're a little forgetful, or there's been some changes in maybe they getting lost in the car a couple times, stuff like that. At that point, it's very hard to assign a type of dementia. So when we look at dementia, you know, and I'm going to give a cursory of the pie. And the reason I say that is the word we use as dementia means that there's cognitive impairment. That is the generic term for anyone that has cognitive impairment. What type of dementia is what is a pie, and each piece of the pie. Now, for instance, Alzheimer's is a very big piece of that pie. It is close to 40% of all people with cognitive issues have dementia. Alzheimer's in general is very, very slow over a lot of years. It does not happen overnight. You can't see it. It's like paint drying. You cannot see the changes. And it's global, meaning it affects the whole brain, not a piece of the brain. When the brain works, one part of the brain does speech, one does swallowing. There's 38 parts of the brain. So when someone has Alzheimer's dementia, is a very slow process, and it's throughout the brain. So it's a little bit of all these parts of the brain are affected. The exact opposite is when you have vascular dementia, which are strokes, because that is the type of dementia that happens in specific times because you have a stroke. Now, when you have 38 parts of the brain, only one might be affected. So 37 parts are perfectly normal, and one part is 50% abnormal. So maybe you're totally fine, but you can't add 2 + 2. Or maybe you're just one arm doesn't work, but the rest of your body does. Well, that's a big difference when you're looking at someone. So when I meet someone and the family's telling me how this has progressed, if someone says, I don't know when this started, I don't know how it started, it's just over 2 years, it's just gotten a little worse and a little worse. Most likely, and especially if they're a little on the older side, you're looking at more of an Alzheimer's type dementia. If they tell me that my mom was fine and then last Christmas she fell and broke a hip and she was never the same, 2 months later she got a cold, she was never the same. We call it a stepwise progression. That is more like mini strokes or strokes that cause changes in the brain. So, so that's a little bit how I look at it. Now, they're the two most common parts. About 85% of all dementias are those two. So there are other types of dementia that are very common, one of which is Parkinson's disease. About a third of people that have Parkinson's end up with Parkinson's type dementia. Now, how does it present? It's pretty easy. Someone has Parkinson's, it's getting worse, and they're getting confused. So it's a pretty easy way to kind of tell what type of dementia it is. The fourth type of dementia, which is very common, or it's close to 10%, is alcohol. Someone that has been drinking alcohol, and does not have to be an alcoholic. It's someone that drinks alcohol on a daily basis, causes damage to the brain. Again, it's a general type of dementia. It's a little hard until you get a really good history and you find out that someone's been drinking 2 highballs before bed every night for their last 40 years. Someone like that can happen. That could be a person that ends up with an alcoholic dementia. Now, right with just those 4, we're over 95%. So of those 5% that are left, there are 10,000 causes. So it's a little hard once we get to that part. But once we get to a part that we're not sure what it might be, and it looks like it's not one of the normal ones, that's when testing happens. And that's when we have to do blood work. We have to do a brain scan. We have to do different testing like that to get a little bit more specific. Once we do some scanning of the brain, it gives us a little bit more specific about what might it be, such as, and I don't know, has everyone ever heard of frontal temporal dementia? Now, that is a type of dementia that's really not much different than Alzheimer's, but it's a little bit more, instead of it being totally globally through the brain, it's more in the front temporal area. What does that mean? It means that there's more behaviors in that part of the brain. So therefore, you have more behaviors associated with this dementia. If you've heard of Lewy body dementia, Lewy body is associated mostly with people with Parkinson's. And the reason it's important is because it's a much quicker dementia. And because it's so quick, it has also behaviors associated with it. So back to Rob's question is, why is it important to know what type it is? Because it's a little easier to predict what's going to happen, understand how we're going to go forward with not only treating it, but what's this lifestyle going to need? What kind of, is this going to be 4 or 5 years before we see it get worse? Or is this going to be worse in 6 months? So it makes you have to make decisions, or it makes your family have to be in a better position to ask those questions. The sooner you know, or more you understand. So it's not possible. If someone that's 90 years old comes to my office and it surely looks like it's Alzheimer's dementia, it's really not, you're not going to gain any new information by doing $1 million worth of tests. But if a 66-year-old that's healthy and still working comes to me and they're having cognitive difficulty, I will order 1 million tests to figure out exactly what's going on, because this person has a life expectancy of 30 years, not a year or 2. So, it's a little bit different depending on the situation. But I hope I gave a little bit more of an overview of what my expectations are.
Yeah, that was great, Rob. So just for clarity from the management perspective. So let's say that someone comes to your office and you have determined by process of elimination and by testing that you think they either have a Lewy body or a frontal temporal. They are more likely, and I'm concluding, but I want your answer, they are more likely to have behavioral issues, meaning they'll be harder to manage than your average Alzheimer's patient, or do you think that that's not necessarily accurate?
Unfortunately, it's very hard on the brain and the body to have cognitive impairment. So everyone that goes through this decrease or change in cognition has behaviors, whether it's depression, whether it's anxiety, whether it's frustration. Emotions are always part of this process. Okay, so the answer to you is yes, people with Lewy body and frontal temporal have a little bit more exaggerated emotions than the general. But I will tell you that I have Alzheimer's patients that are much worse than a lot of Lewy body patients. So you want to, people like to define things. They want to know what's going to happen. But I will tell you that it's not all of these patients. Everyone that develops Alzheimer's or a dementia is prone to having behaviors. So I would not put things off of decision making because, oh, my mom had Alzheimer's and she'll be fine for the next couple years. It doesn't work like that. No two people are the same, and anyone that tries to predict it is going to be wrong. All you can do is be prepared, and that's all I can do. And when I send them to Rob, that's all he can do. We can only prepare you, not necessarily for the worst, but we've got to have that on the horizon. That if this is bad, what are we going to do? How are we going to look at things if things got bad quickly? So as much as we want to predict, we have to assume that it's not going to be good, and it potentially could be bad.
Now,
And that's kind of how I treat my families, that it's one day at a time. Mom looks great today, and she could look great tomorrow and 6 months from now. I just don't know, and no one's the same.
You and I, again, have been friends for a very long time, and I've seen, and I think you've seen too, where I'm more sensitive to younger patients with cognitive impairment, because now I'm getting to the age where that could be me.
Right.
And when I, get the occasional, although not as occasional as it used to be, it's interesting because many years ago when we first met, most of my clients were pretty old. They were usually in their late 70s to 90s getting, if I was doing a guardianship or something. And today I'm seeing a lot more people who have cognitive impairment at scary young ages, like late 50s, early 60s. Have you found in your practice that you see more of those type of patients with a particular type of neurocognitive impairment, or it just is all over the board? It could be Alzheimer's, could be Lewy body, could be any of the other ones.
The answer is yes and no. We are definitely more aware of these problems sooner. So we're not blowing it off like we used to. I mean, dementia has become a real problem, and it's not something to not take seriously. So I think that we're seeing more, and we are. There are certain dementias that actually are more premature. Alcohol is a big one. Chronic concussions, CTE is something that we're seeing more of. So there are, from a mathematical standpoint, we are seeing some more at younger ages. But I think that we're just a lot more prepared in evaluating them than we used to. And I think that a lot of these neurocognitive changes, and that's what we call younger people that end up with mild dementia. I think that years ago, it always went the route of psych. They were kind of thrown into the psych arena. Whereas we found out that that's not true, and that's not fair. Just because they have an emotional overlay to their cognitive decline does not mean that they're primary psych. So I think we're much better at that than we were 15, 20 years ago. When we used to get phone calls, we ended up committing these people, and they ended up going through the psych wing of medicine. So I think answers part of your question, Rob.
Michelle Crook has her hand raised. Michelle.
Hi, good afternoon. I have a quick question, if that's okay.
Sure.
Great. So just to clarify, in terms of cognitive issues and the diagnoses of dementia, we can have overlap, correct? We could have overlap between the different types of dementia.
Absolutely. Which when I'm lecturing my residents and interns, the first question I ask is, how can you have 40% of Alzheimer's, 40% of vascular dementia, 10%, and then all these other dementias, because they equal more than 100%. So the pie is bigger than 100%. So actually, if you live long enough, for instance, a 90-year-old, the chances of them having both Alzheimer's and vascular dementia is almost 20%. So there is an overlap.
Are there any other questions that you want to ask Rob before we kind of move into the next direction?
I have a question. I I've been hearing a lot about how important sleep is and sleep throughout your life, not just sleep as you are having the symptoms. Can you talk a little bit about that?
Well, if you ask my wife, she and I have a little bit of a different opinion.
Is
If
she
you know,
here? That could be fun.
yeah, a study just came out actually yesterday or the day before that said that there is to people that lack sleep have a higher incidence of dementia. And I'm one of those people that sleeps 4 hours a night. So I don't sleep a whole lot. And my wife, every time an article like this comes out, it's on my pillow when I go to sleep. So she's been telling me this for years. I have not and I do a lot of work in this arena because dementia is probably my subspecialty. There really is nothing obvious that would cause one versus the other. But that's not to say that there are certain sleeping habits and the way people deal with lack of sleep that can cause some type of impairment over time.
Thank you.
I have a quick question as well. Hearing loss and dementia, is there a strong correlation between the two?
Zero.
Okay.
Zero. But I will tell you that there are people with hearing loss that we get confused because we think they're confused, but they're actually not hearing well.
Understood.
But it's a good question, but the answer is exactly zero. There is no correlation between the two.
Okay. And I know there's no cure. There's nothing, we could all talk about everything in moderation and diet and keeping ourselves, brain active and physically active. Is there any type of supplements or anything that you suggest, Dr. Pearlstein, that other folks can take? There's so much out there about, different vitamins and supplements. What's that?
I keep watching the commercials on television and they're very clever. I will tell you that in the geriatric field, we have not shown any of them to be any help at all. There is no proof that all these fancy drugs that you keep hearing on television are any better than Centrum Silver. It is a multivitamin, and there's a lot of different things in a multivitamin, and there are in them. I wish I could tell you that all those vitamins do what the ads tell you, but there's been shown no proof. Now, back to your the first part of the question is what you can do. You're right. Living a healthy lifestyle, for one, the younger you are, the better you can prevent any issues. Your brain's a muscle. The more you use it, the better it's going to do. So, and there's definitely a large emotional overlay on having some dementia. So by keeping someone's confidence up and keeping people moving and doing and using their mind is the best thing you can do. Because the more confidence someone has, they can still go out to dinner. The more they'll do it and the better they'll do from an overall sense. They might not do overall better from a mathematical sense, but they will do it better in a quality of life sense.
Okay, great. So we're just going to switch gears very briefly, just to give some of the tools on the asset side, protection side, thinking ahead. Now, one of the things that, if anybody here has ever been to any of my presentations, you know how I hammer on the necessity of a good, comprehensive, well-drafted power of attorney. And having someone appointed, someone that you choose, and giving them the authority that they need to help you is absolutely essential in doing good long-term care planning. One of the things that I will often do, and one of the questions you might have is, well, at what point can't someone sign these documents? Well, one of the things that I will often do is, rather than utilizing my own common sense, and obviously I try to use that too, but one of the things I will often do is, if I have a client who's already got a diagnosis of mild cognitive impairment, I use my own senses and determine whether they understand the concept of a power of attorney and they feel comfortable with the people that they discussed with me they want to name as their trusted party. But whenever there's a borderline person, I don't use I want someone else to second guess me. And this is where I might call Rob and say, hey, Rob, I want you to assess this individual and give me your feelings as to whether they fully can comprehend the concept of a power of attorney and have the ability to truly understand what they're giving away. Because, I don't believe that someone who has a mild level of impairment can't execute a power of attorney. But it's a very gray area as to when they step over that line to where they are not really capable of understanding the consequences of their actions. And that's where I normally would want an expert to kind of do that. It's not only for my protection and for the protection of the person that they appoint who wants to do the right thing, but it's also to protect, the individual, so nobody feels at any point that they were being taken advantage of. So I think that's important. When we look at the things that
Rob,
yeah.
let me add to that. That's a very important what you said. I've been in court 7 or 8 times for lawyers that have changed power of attorneys with the person that they're changing is not competent to make that decision. And it happens and we've all dealt with this. Not every family is happy and friendly and on the same page. So I've had many times where a family member takes someone out of a facility, goes to their lawyer changes their will and everything. So it's important that we watch and make sure that things aren't done inappropriately. And Rob is correct. If you're not 100% sure that that person understands exactly what the process is, then you need a person to confirm that.
And by the way, I will give you a very precise example that if you want to look through the records of the Montgomery County Orphans Court, because about 2.5 years ago, a colleague of mine who was a litigator in Orphans Court called me up and he said, Rob, I'm fighting a will contest. And I'm like, okay, great. I need your help. I want you to be a witness. Well, why? Well, 1, you're an expert in the area. And 2, the son who got another will drafted by another attorney came to you first. And I was like, oh, I remember that name. Yeah, I remember that guy. He was an idiot. I didn't like him at all. But the guy called me and said, I want you to do this and I want you to do that. And his mother, the first indicator for me of that case was that his mother was recently discharged from Suburban Senior Behavioral Unit. But that doesn't necessarily mean that the woman doesn't have capacity. It means she had some issues that may have been addressed. But when I went back through this 10-plus-year-old file, I found that, in fact, I had sent the family and I said, look, I'm not doing any documents for your mother until somebody evaluates her and gives me, an appropriate answer as to her level of cognition. And you know who that person, what I found out when I went back through my records were, that person was Dr. Robert Pearlstein. And I went back and I saw the emails and the conversations and the notes and the memos I had in the file. And I said to the family, I am not doing any documents. We are either going for a guardianship or you can find another lawyer. Well, he found another lawyer and that lawyer did some stuff that was inappropriate. And the only reason I'm mentioning this to you is because when the attorney who asked me to testify came back to me several months later after the judge had issued her opinion, because it was an appeal that was being taken. The judge has issued her opinion, and the judge made a point in this opinion of hers to say, Mr. Slutsky was the only attorney of the 3 involved who actually did the due diligence and had this person's cognition checked out, and he was the one who was right to tell the family we're either going to do a guardianship or we're not going to get involved. And she made it was a crystal clear point. I will always remember that because the lawyer was like, Rob, you won my case for me. But it wasn't about winning the case. It was about doing due diligence in a situation where we're in a gray area. And the fact is, nobody knows the future, like Rob has said. And you can't just assume that just because someone can articulate clearly for a 5-minute discussion that they want this, this, or this, you have to look at the big picture. And when you have a geriatrician who does assessing of individuals, they don't just go by the medicals. They look at the big picture because they have that experience of seeing literally hundreds and hundreds of people in different settings where they can determine someone's capacity better than, for instance, and I'll tell you right now, my wife is an internal medicine doc. Her ability is, and she's an extraordinarily good doc, but her ability to assess cognition is very different from what Rob and his staff are, because they're doing it every single day. So we've got the tools, we've got the powers of attorney. You know, in the rare cases, we might use a trust, but it's important, as Rob has been saying, that you need to hit this stuff before it becomes a crisis. Yes, we can deal with crises. It's our practice. Our practice is crisis oriented by nature, because we get a lot of people who have health events, and then we have to address those health events to try to help them pick the right care, get to the right place, figure out a way to pay for it, assess the finances, et cetera, et cetera. But the idea is, the more pre-planning you do, the more setting up for the eventual crisis. And ultimately, someone, you know, it's rare when someone who is diagnosed doesn't have that crisis down the road. Yes, some people are very, they have a very moderate decline and their behaviors stay good and their family's able to keep them at home. But that's a more rare instance. More likely, people will decline cognitively, physically. They'll need a higher level of care, whether it can be provided in the home or not. Some will have significant behavioral issues that kind of compel a more aggressive stance on care. But the point is, the more you address up front, the more education, the more knowledge, the more planning you do, inevitably the outcome is going to be better. Because in those cases, there are less instances where we're forced to get a guardianship, where we're forced to 302 someone. A 302 is an involuntary admission to a psychiatric facility. But when we have, for instance, a good geriatrician on board, sometimes behaviors can be moderated with diet and medication so that we don't have those explosive behaviors that cause the need to put someone in a psych unit. So there's a lot of tools that are available to us if we attack these problems in the beginning. If when we start to see these issues coming up on the front end before. So one of the problems we have, for those of us who have been caregivers, and I have been, and pretty much everybody in this room probably has, but the decline is often a gradual one. And sometimes you don't notice those steps that Rob was describing earlier. Sometimes you do. But when you don't always see it, because you see gradually mom or dad is now a little bit more impaired, but you're compensating, they're compensating. And let's be real, some people have the ability to compensate in a very safe way. They write themselves notes, they follow the notes, they take their meds when they're supposed to, and they're very good and very regimented, and they don't need a lot of intervention. And then there's the vast majority of people who can't pull it together enough to be that organized. And in those cases, you need a more significant, more intrusive intervention, but ultimately we're about safety and quality of life. So, you know, this effect, we got to remember that when we're talking about elder care, it's not just about the individual's needs. There are stakeholders. It's about the caregiving child, the caregiving spouse, the individual who is suffering from the condition. But there's usually so many more pieces to the puzzle that we have to consider all of these different parties when we're looking at the planning, because, you know, one of the things that I'm sure Rob deals with too is the tremendous guilt that loving families deal with, that they feel like, I want to care for my spouse or my dad until he dies in his home. And they feel terrible when they have to say, look, we're going to force an outsider to come in and take care of you, or we're going to have to put you into a community that has the resources and the staffing to make sure you're safe 24/7. So when we talk about those, these are all the tools. The tools that we deal with are legal, financial, medical, psychosocial. You know, sometimes, like Rob said, you know, depression in the senior community is just widespread. So many seniors, even if they're not diagnosed with a cognitive impairment, are suffering from isolation, depression. All of these things affect the way they live their lives, their quality of life, and in my case, often their ability to be taken advantage of. You know, someone who represents older adult protective services, one of the things that we see, and I think Rob will agree with me, that it is at the beginning of the dementia or the neurocognitive impairment process that people are most vulnerable, because at that point they often don't recognize that they need help, or that they can be taken advantage of. They still think that they have it. And that's where they are typically led to situations where they're making really bad ones. Because typically, the farther along they become, the more they're willing, and as long as they recognize their deficits, they're more willing to lean on family and to listen to professionals. And at that point, they're actually less likely to be taken advantage of, because oftentimes they lack the ability. But what I see often is people who you would not even recognize have cognitive impairment, who then write a check for $68,000 and send it to a P.O. box in Houston. And I have seen that. And it is amazing how all of the different professionals are so necessary to be a team. So, you know, I'm very thankful to have Rob as a colleague and a friend, and I very much appreciate his willingness to educate everybody here today. Does anybody have any questions for Rob or Rob? Or Rob? Well, I know Heather's going to have something to say, and Rob might want to have something to say. Heather, you're going to give everybody Rob's office contact information, right?
Absolutely. Yes.
Okay. Well, I appreciate, you know, Rob as a friend, as a colleague, as a resource. He has been enormously helpful over the years, and you know, and I appreciate the information he gives to all the people when we have these coffee chats.
Thank you. Dr. Rob Pearlstein, would you like to add anything else?
No, I think that the take home here, and we're all coming from different, we're all looking at it from a different angle. I just think that we're always better to be proactive than retroactive. And, you know, when dealing with this, not only is it good for the person because you can treat it, you can plan for it, but there's so many issues that you end up with if you don't. And those issues are tough, you know, and not only are they tough, they're expensive. So a lot of these things, we really, I mean, I try my best when we have issues with families, getting the family together, discussing the problems, seeing what everyone wants. It's so important to know what a loved one wants. Well, they can tell you, than you trying to figure out what you think they might want. So these are all things that, again, being proactive is the take home here from a medical as well as the legal end of all of